Irritable bowel syndrome, IBS. Definition: Irritable bowel syndrome, IBS, is a group of symptoms including abdominal pain and changes in the pattern of bowel movements without any evidence of underlying damage. Irritable bowel syndrome, IBS, is a functional gastrointestinal (GI) disorder characterized by abdominal pain and altered bowel habit in the absence of a specific and unique organic pathology, although microscopic inflammation has been documented in some patients. Irritable bowel syndrome, IBS, is a common functional disorder of GI motility not associated with anatomic changes. It is also known as spastic colon or irritable colon. Classification: 4 bowel patterns may be seen with irritable bowel syndrome, and these remain in the Rome 4 classification. These patterns include the following: IBSD, diarrhea predominant; IBSC, constipation predominant; IBSM, mixed diarrhea and constipation; IBSU, unclassified. The symptoms cannot be categorized into one of the above 3 subtypes. Risk factors: many people have occasional signs and symptoms of IBS. People at the risk are young. IBS occurs more frequently in people under age 50. Are female. IBS is more common among women. Estrogen therapy before or after menopause also is a risk factor for IBS. Have a family history of IBS. Genes may play a role, as may share factors in a family's environment or a combination of genes and environment. Have a mental health problem. Anxiety, depression and other mental health issues are associated with IBS. A history of sexual, physical or emotional abuse also might be a risk factor. Causes: the precise cause of IBS isn't known. Factors that appear to play a role include muscle contractions in the intestine. The walls of the intestines are lined with layers of muscle that contract as they move food through digestive tract. Contractions that are stronger and last longer than normal can cause gas, bloating and diarrhea. Weak intestinal contractions can slow food passage and lead to hard, dry stools. Nervous system: abnormalities in the nerves in digestive system may cause patient to experience greater than normal discomfort when the abdomen stretches from gas or stool. Poorly coordinated signals between the brain and the intestines can cause the body to overreact to changes that normally occur in the digestive process, resulting in pain, diarrhea or constipation. Inflammation in the intestines. Some people with IBS have an increased number of immune system cells in their intestines. This immune system response is associated with pain and diarrhea. Severe infection. IBS can develop after a severe bout of diarrhea, gastroenteritis, caused by bacteria or a virus. IBS might also be associated with a surplus of bacteria in the intestines, bacterial overgrowth. Changes in bacteria in the gut, microflora. Microflora are the good bacteria that reside in the intestines and play a key role in health. Research indicates that microflora in people with IBS might differ from microflora in healthy people. Triggers. Symptoms of IBS can be triggered by food. The role of food allergy or intolerance in IBS isn't fully understood. A true food allergy rarely causes IBS. But many people have worse IBS symptoms when they eat or drink certain foods or beverages, including wheat, dairy products, citrus fruits, beans, cabbage, milk and carbonated drinks. Stress. Most people with IBS experience worse or more frequent signs and symptoms during periods of increased stress. But while stress may aggravate symptoms, it doesn't cause them. Hormones. Women are twice as likely to have IBS, which might indicate that hormonal changes play a role. Many women find that signs and symptoms are worse during or around their menstrual periods. Pathophysiology. Signs and symptoms. Manifestations of IBS are as follows: altered bowel habit, abdominal pain spasm, abdominal bloating distension. Altered bowel habit in IBS may have the following characteristics. Constipation variably results in complaints of hard stools of narrow caliber, painful or infrequent defecation, and intractability to laxatives. Diarrhea usually is described as small volumes of loose stool, with evacuation preceded by urgency or frequent defecation. Postprandial urgency is common, as is alternation between constipation and diarrhea. Characteristically, one feature generally predominates in a single patient, but significant variability exists among patients. Abdominal pain in IBS is protean, but may have the following characteristics. Pain frequently is diffuse without radiation. Common sites of pain include the lower abdomen, specifically the left lower quadrant. Acute episodes of sharp pain are often superimposed on a more constant dull ache. Meals may precipitate pain. Defecation commonly improves pain but may not fully relieve it. Pain from presumed gas pockets in the splenic flexor may masquerade as anterior chest pain or left upper quadrant abdominal pain. Additional symptoms consistent with irritable bowel syndrome are as follows. Clear or white mucoria of a non-inflammatory etiology. Dyspepsia, heartburn. Nausea, vomiting. Sexual dysfunction, including dyspareunia and poor libido. Urinary frequency and urgency have been noted. Worsening of symptoms in the perimenstrual period. Comorbid fibromyalgia. Stressor-related symptoms. Diagnosis. History taking. Assess family history of IBS, pattern of GI upset, duration of illness, medication history. Physical examination. The typical triad of findings in IBS include abdominal pain with tenderness on palpation. Abdominal pain may be localized in the left lower quadrant, be constant or intermittent, and be relieved by passing flatulence or stool. Altered bowel habits, such as diarrhea or constipation. Diarrhea often alternates with constipation. Stools may contain increased mucus but seldom contain blood. Absence of detectable disease. Symptoms often mimic those of other conditions, hindering the differential diagnosis. The diagnosis must first exclude any organic GI disease or abnormality. Flexible sigmoidoscopy. To examine the lower part of the colon, sigmoid, with a flexible, lighted tube, sigmoidoscope. Colonoscopy. It uses a small, flexible tube to examine the entire length of the colon. X-ray or CT scan. These tests produce images of abdomen and pelvis that might allow physician to rule out other causes of symptoms. The doctor might fill large intestine with a liquid, barium, to make any problems more visible on X-ray. This barium test is sometimes called a lower GI series. Lactose intolerance tests. Lactase is an enzyme which is needed to digest the sugar found in dairy products. If body does not produce lactase, client may have problems similar to those caused by IBS, including abdominal pain, gas and diarrhea. Breath test for bacterial overgrowth. A breath test also can determine if there is bacterial overgrowth in small intestine. Bacterial overgrowth is more common among people who have had bowel surgery or who have diabetes or some other disease that slows down digestion. Upper endoscopy. A long, flexible tube is inserted down to throat and into the tube connecting mouth and stomach, esophagus. A camera on the end of the tube allows the doctor to inspect upper digestive tract and obtain a tissue sample, biopsy, from small intestine and fluid to look for overgrowth of bacteria. Stool tests. Your stool might be examined for bacteria or parasites, or a digestive liquid produced in liver, bile acid, if client have chronic diarrhea. Diagnostic criteria for IBS. Rome criteria. These criteria include abdominal pain and discomfort lasting on average at least 1 day a week in the last 3 months, associated with at least 2 of these factors. Pain and discomfort are related to defecation, the frequency of defecation is altered, or stool consistency is altered. Manning criteria. These criteria focus on pain relieved by passing stool and on having incomplete bowel movements, mucus in the stool and changes in stool consistency. The more symptoms client has, the greater the likelihood of IBS. Management. Mild signs and symptoms can often be controlled by managing stress and by making changes in diet and lifestyle. Try to Avoid foods that trigger symptoms. Eat high-fiber foods. Drink plenty of fluids. Exercise regularly. Get enough sleep. If problems are moderate or severe, doctor might suggest counseling, especially if client has depression or if stress tends to worsen symptoms. Fiber supplements. Taking a supplement such as psyllium, metamucil, with fluids may help control constipation. Laxatives. If fiber doesn't help symptoms, doctor may prescribe magnesium hydroxide oral, Phillips milk of magnesia, or polyethylene glycol, Miralax. Antidiarrheal medications. Over-the-counter medications, such as loperamide, Imodium, can help control diarrhea. Doctor might also prescribe a bile acid binder, such as cholestyramine, Prevalite, Colstipol, Colstid, or Colsvlum, Welchol. Bile acid binders can cause bloating. Anticholinergic medications. Medications such as dicyclomine, Bentyl, can help relieve painful bowel spasms. Tricyclic antidepressants. This type of medication can help relieve depression as well as inhibit the activity of neurons that control the intestines to help reduce pain. If client has diarrhea and abdominal pain without depression, doctor may suggest a lower than normal dose of imipramine, tofranil, desipramine, norepramine, or nortriptyline, Pamela. SSRI antidepressants. Selective serotonin reuptake inhibitor, SSRI, antidepressants, such as fluoxetine, Prozac, Seraphe, or paroxetine, Paxil, may help if client is depressed and have pain and constipation. Pain medications. Pregabalin, Lyrica, or gabapentin, Neurontin, might ease severe pain or bloating. Medications specifically for IBS. Medications approved for certain people with IBS include IBSD, Allostrone, Lotronex. Allostrone is designed to relax the colon and slow the movement of waste through the lower bowel. Allostrone can be prescribed only by doctors enrolled in a special program, is intended for severe cases of diarrhea-predominant IBS in women who haven't responded to other treatments, and isn't approved for use by men. Elaxadiline, Wiberzi. Elaxadiline can ease diarrhea by reducing muscle contractions and fluid secretion in the intestine, and increasing muscle tone in the rectum. Side effects can include nausea, abdominal pain and mild constipation. Elaxadiline has also been associated with pancreatitis, which can be serious and more common in certain individuals. Rifaximin, Xifaxan. This antibiotic can decrease bacterial overgrowth and diarrhea. IBS-C. Lubiprostone, Amitiza. Lubiprostone can increase fluid secretion in small intestine to help with the passage of stool. It's approved for women who have IBS with constipation, and is generally prescribed only for women with severe symptoms that haven't responded to other treatments. Linaclotide, Linzess. Linaclotide also can increase fluid secretion in small intestine to help client pass stool. Linaclotide can cause diarrhea, but taking the medication 30 to 60 minutes before eating might help. Potential future treatments. Researchers are investigating new treatments for IBS. Serum-derived bovine immunoglobulin protein isolate, SBI, a nutritional therapy, has shown some promise as a treatment for IBS with diarrhea. Studies also show that, in people who have IBS with diarrhea, a specially coated tablet that slowly releases peppermint oil in the small intestine, enteric-coated peppermint oil, eases bloating, urgency, abdominal pain and pain while passing stool. Nursing management. Nursing diagnosis. Diarrhea. Constipation. Risk for deficient fluid volume. Anxiety. Acute pain. Ineffective coping. Imbalanced nutrition, less than body requirements. Deficient knowledge. Interventions. Teach the client measures to reduce symptoms by eating a well-balanced, high-fiber diet, avoiding gas-forming foods, and avoiding fluid intake with meals because it causes abdominal distension. Adhering to a schedule of regular work and rest periods. Participating in regular exercise, which reduces anxiety and increases intestinal motility. Avoiding or minimizing stress-producing situations. Drinking 6 to 8 glasses of water daily, not at meals, to prevent constipation. Adhering to a regular eating schedule and chewing food slowly and thoroughly. Promote client and family coping. Provide the client with reassurance and emotional support to help decrease anxiety and increase his sense of control over the situation and its management. Administer medications, which may include anticholinergics, antispasmodics, antidiarrheals, and bulk laxatives. Complications. Chronic constipation or diarrhea can cause hemorrhoids. In addition, IBS is associated with poor quality of life. Many people with moderate to severe IBS report poor quality of life. Research indicates that people with IBS miss 3 times as many days from work as do those without bowel symptoms. Mood disorders. Experiencing the signs and symptoms of IBS can lead to depression or anxiety. Depression and anxiety also can make IBS worse.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.